Now we are going to discuss the next topic on malignancies in the gallbladder and biliary system. Okay, malignancies in the gallbladder and biliary system we are going to discuss now. So one of the important topics for AIIMS and PG Chandigarh. So usually NEET exam the questions are very less, but for AIIMS this question regularly comes. So this is right duct, left duct, common duct, cystic duct, gallbladder. This is the biliary system. Can you tell me where the cancer is most common in the biliary system? Cancer is more common in the gallbladder. The most common site of cancer in the biliary system is gallbladder. And in bile duct, the cancer is common in this place. This is known as hilum, and this tumor is known as Klatskin tumor. Please don't forget, the most common site of malignancy in the biliary system is gallbladder, and the most common site of cancer in the bile duct is at the hilum, that is known as Klatskin tumor. That is known as Klatskin tumor. Okay, so in gallbladder and biliary system, the classical clinical features are they will come to you with a pain, abdomen, and most of the time the symptoms will mimic like a acute cholecystitis, because many times the gallbladder cancer will have associated stones, and many times they mimic like a biliary colicky pain. So pain, abdomen, and jaundice, weight loss are the classical clinical features of gallbladder and biliary malignancy. So now, at this point of time, let me tell you about obstructive jaundice. Obstructive jaundice we must understand in this point of time. So obstructive jaundice is mainly due to two reasons. What are they? It can be either due to stone or it can be either due to cancer. So stone or cancer are the two important reasons. How to find out whether it is stone or cancer by clinical examination method? That is method was explained by a law known as Cour-Weisier law. Please don't forget Cour-Weisier's law. So please understand Cour-Weisier's law. So Cour-Weisier is a famous physician, lived long back. One day two people came to him. One fellow Mr. Ramu and another fellow Mr. Somu. They both came to him with a severe obstructive jaundice. Please remember, they are with a severe obstructive jaundice, they both came to him. And now our physician Cour-Weisier is going and examining their abdomen. On examining Ramu, he found out his gallbladder is this much enlarged. On examining Somu, he found out no gallbladder enlargement at all. No gallbladder enlargement. So no GB in one person and GB is enlarged in another person. So now, according to Cour-Weisier law, who is having stone and who is having cancer? Can you tell me? Ramu or Somu? So this is Ramu, this is Somu. So always please remember, in my topic of discussion everywhere, Ramu is always a bad lucky fellow. Okay, remember like that. So Ramu is having a hugely enlarged gallbladder. He's having a huge enlarged gallbladder. Therefore, he is having cancer. Cancer in the bile duct system, in the biliary duct system. Somu is not at all having gallbladder cancer, and Somu, the reason for obstructive jaundice is stone. Stone in the CBD. So now understand what is happening inside. So what is happening inside of Ramu is there is some cancer either in the distal CBD or mid CBD. There is a cancer. Because of cancer, the bile is getting stagnated and the gallbladder is enlarging because it is a normal gallbladder. So the gallbladder is enlarging with full of bile. So therefore, if there is a cancer, gallbladder will become enlarged. And in Somu, please understand, there is a stone in the bile duct. Where is the stone come from? Where is the stone? From where this stone would have come from? The stone is coming from gallbladder only. So that means this gallbladder would have been previously many times inflamed and would have been thickened. So this is a cholecystic gallbladder. So it is a cholecystic gallbladder. So it will not enlarge even if there is obstruction. The gallbladder is already contracted and will not enlarge. This is known as Goodsall rule. If it is due to stone, the gallbladder will not be enlarged. If it is due to cancer, the gallbladder will be enlarged. If it is due to cancer, gallbladder will be enlarged. This is what we say as Cour-Weisier law. So Ramu will die soon, Somu will not die soon. So telling this concept of Cour-Weisier law, let us assume Cour-Weisier died. And our people found out two exceptions. No, in cancer also gallbladder will not be palpable. What is that exception? Cancer also, gallbladder not palpable. What is the answer? Some of the Indian textbook gives multiple reasons, but the correct reason is a cancer in the hilum. Cancer in the hilum. Hilar cancers or Klatskin tumors. Gallbladder will not be enlarged because the obstruction is more proximal. So the gallbladder will not be enlarged. This is exception number one. So please remember, in a cancer, when will gallbladder not enlarge? Means if the cancer is in the proximal level at the level of hilum. Tell me, in stone, where gallbladder is enlarged, in spite of stone obstructing the bile duct, the gallbladder will be enlarged if there is double impacted stone, another stone in the cystic duct. The gallbladder will enlarge because of mucocele. So this is exception number two. Other exceptions which are given in book are not real exceptions. So the exception number one is Klatskin tumor is one exception. Exception number two is double impacted stone is exception number two. Please don't forget these two exceptions in a Cour-Weisier law. So please don't forget Cour-Weisier law. This is high yield MCQ topic, Cour-Weisier law. So according to Cour-Weisier, if there is gallbladder enlarged, it is cancer. If gallbladder not enlarged, it is stone. That is the reason for these two cases. Please don't forget these two patients with the Cour-Weisier law. So Ramu and Somu has explained you the Cour-Weisier law very clearly for you. Now let us discuss first about gallbladder cancer in detail. So gallbladder cancer, what are the predisposing factors? What are the predisposing factors for gallbladder cancer? The most common is gallstones. Please don't forget, the most important predisposing factor is gallstones. How many percentage of gallstones will cause cancer? 0.5% will result in cancer. This is what I told you. But how many percentage of cancer will have stones? How many percentage of cancer will have stones? Please remember, interesting point, 95% of the cancer gallbladder will have stones. So 95% of the cancer gallbladder patients will have associated stones. In other words, all stones will not lead to cancer, but all cancers will have stones. All cancers will have stones. So 95% of the patients will have gallstone. This is the most common association of gallbladder cancer, and the association is 10% when the stone size is 3 cm or more. When there is a very big stone, there is 10% association of cancer. So what are other predisposing factors? Other predisposing factors are polyps, typhoid carriers, polyps more than 10 mm enlarged, typhoid carriers. So typhoid carriers, estrogen drugs, and Clonarchis sinensis. It is a Chinese liver fluke which can cause cancer gallbladder, ulcerative colitis, And please don't forget the topics we just now discussed. They are choledochal cyst. They are choledochal cyst and also primary sclerosing cholangitis. Choledochal cyst also known as anomalous pancreatic bile duct junction patients. And many carcinogens are there. So many carcinogens are there which can cause cancer of the gallbladder, like nitrosamines, like rubber dyes, rubber industry, and various dyes and chemicals can also cause gallbladder cancer. So please don't forget the causes of gallbladder cancer, predisposing causes of gallbladder cancer. And in this, please don't forget the Clonarchis sinensis can cause gallbladder cancer. And another important predisposing factor already we discussed is porcelain gallbladder. So porcelain gallbladder, gallstones, polyps. These are the three things we have to operate even if they are asymptomatic. In gallstones, when it is more than 2.5 centimeter, we operate. So these are the predisposing factors. So now, investigations for gallbladder stone, so gallbladder cancer. So usually the patient comes to you with a pain in the right hypochondrium, and routinely we do ultrasound abdomen, and ultrasound abdomen may or may not pick up the cancer, but it will pick up the gallstones. So gallstones associated with cori polyp, you should suspect cancer. So if there is a gallstones associated with cori polyps or cancer, will be the report given by the radiologist. That is not the investigation of choice for gallbladder cancer. So investigation of choice to diagnose gallbladder cancer is CECT abdomen with triple phase contrast. You will understand what is triple phase in liver chapter. So with the triple phase CECT abdomen should be done. That will show you the gallbladder malignancy. Please don't forget, that will show you the gallbladder malignancy. And what is the tumor marker for gallbladder cancer? The tumor marker is CEA. CEA is a tumor marker for gallbladder cancer. For bile duct cancer, so for bile duct cancer, investigation of choice is MRCP associated with MR angio should be done. And tumor marker for bile duct cancer is CA19-9 as well as CEA. Both are done for bile duct cancers. So these are some of the investigations asked in exam. So please don't forget, gallbladder cancer also has CEA as a tumor marker. Bile duct cancer has CEA and CA19 both as tumor markers. So bile duct cancer staging investigation is MRCP with MRA, and for gallbladder cancer it is CECT abdomen. With all these investigations, we will do staging for the cancers. Now let us discuss staging of gallbladder cancer. So staging of gallbladder cancer is very important because based on that only we manage also. So therefore I am discussing both together, staging and management side by side I am going to discuss for gallbladder cancer. T1A, what is T1A? The tumor is going up to lamina propria, that is going up to lamina propria is known as T1A. Going up to lamina propria is known as T1A. So tumor involving up to lamina propria, the treatment is laparoscopic cholecystectomy is enough. So the biopsy report is showing there is a tumor involving only up to lamina propria, means laparoscopic cholecystectomy is enough. Okay. T1B. So what are the layers absent in gallbladder wall? Can you tell me? The layers absent in gallbladder wall are muscularis mucosa and submucosa are not there in gallbladder. Muscularis mucosa and submucosa are absent in gallbladder. Muscularis mucosa, submucosa are not there. Therefore, T1B is muscularis layer. Muscle layer is T1B. So T1B is muscle layer. So T1B muscle layer, what will you do? A tumor going up to the muscle layer, if there is no perineural invasion, no vascular invasion. If the biopsy report comes as no perineural invasion, no vascular invasion, no lymph node, no margin positive, the tumor margin is negative. So when this comes, the lap cholecystectomy is enough for the patients. So if a tumor is involving up to muscle layer and the biopsy report comes as no perineural invasion, no vascular invasion, no lymph nodes or no lymph node positive, no margin positive, means laparoscopic cholecystectomy is enough for those patients. If by chance, so T1B, all these are becoming positive, what should I do? So perineural invasion positive, vascular invasion positive, or any one of this is positive, what should I do is, I should now reopen the abdomen. This is the place where the gallbladder was previously present. I will reopen the abdomen and I will give a 2 centimeter clearance of the liver and remove. 2 centimeter clearance of liver I will resect. Along with this, I will resect bile duct if margin is cystic duct margin positive, otherwise not done. If cystic duct margin is positive, I will resect the bile duct. If cystic duct margin is negative, no need to resect bile duct. Remove only the nodes. The nodes are pericholedochal nodes, periportal nodes. What are the nodes removed? Are pericholedochal, periportal, celiac nodes, retroduodenal nodes. So pericholedochal, periportal, celiac, retroduodenal, hilar nodes are all removed. This operation is known as extended cholecystectomy. So extended cholecystectomy is an operation done for T1B cases involving the muscle layer with bad factors like perineural invasion, vascular invasion, lymph node positive, margin positive. We have to go for extended cholecystectomy for those patients. That is T1B. Now coming to T2. T2 is a tumor infiltrating up to serosa. Tumor infiltrating up to serosa. Please remember, if your tumor is infiltrating up to serosa, we are going to do major resection. So please remember the segmental anatomy of liver. So you will be discussing this in liver chapter, but remember the segments. This is 2, this is 3. This is 4A, this is 4B. This is segment 5. This is segment 6, segment 7, segment 8. So if the tumor is involving up to the serosa, I will remove these 2 segments. 4B and 5 will be removed. I will reopen the abdomen. And I will go inside and remove 4B plus 5 will be removed. This surgery is known as, along with the nodes already we discussed, along with all the nodes, pericholectal, periportal, perihilar, retroduodenal, all the nodes will be removed. That is known as radical cholecystectomy. See, though I am telling cholecystectomy only the name, it still involves removal of liver also. This is known as radical cholecystectomy. So T1, I will do a simple cholecystectomy is enough. Simple cholecystectomy is enough for T1A. T1B involving muscle, we should do a extended cholecystectomy. T2, I will do a radical cholecystectomy. T2, I will do a radical cholecystectomy. T3, it is involving the adjacent organ is involved, or adjacent visceral peritoneum involved. So what are the adjacent organs? You know, the most common adjacent organ which may be involved is liver. So other organs rarely involved are duodenum, colon, pancreas, bile duct, anywhere it can get involved. So mostly the common nearby organ is liver. If liver is involved, what should I do? If the cancer in the gallbladder is involving the nearby liver, what I will do is, I have multiple options based on the involvement. This is segment 2, this is segment 3, this is 4A, this is 4B, and this is 5, 6, 7, 8. So now the various options if the adjacent organ liver is involved are the following. So I can do number 1, radical cholecystectomy. What are the segments removed? Radical cholecystectomy. Segments 4B and 5 will be removed. That is one option. If it is only restricted to segment 5. If it is going on into the right side of the liver like this, we will go for a extended right hepatectomy. What is this? Extended right hepatectomy means. So in radical cholecystectomy, segment 4B and 5 are removed. In extended right hepatectomy, we remove 4A, 4B, 5, 6, 7, 8 will be removed. That is known as extended right hepatectomy. And sometimes we also remove a hepatectomy, which is very interesting to see. You can see this is a hepatectomy 4, 5 and 8 like this. 4B, 5 and 8 alone will be removed. Looks like a Taj Mahal hepatectomy. Central Taj Mahal type of hepatectomy can be done. So that is known as segment 4B, 5 and 8 will be removed. Is known as central Taj Mahal hepatectomy. So these are the various types of hepatectomy we do for a T3 case. For a T3 case involving adjacent liver. For a T3 case involving adjacent liver, the types of resection are radical cholecystectomy, extended right hepatectomy, or central Taj Mahal hepatectomy. And T4 is more than one organ involved. Or main hepatic artery and portal vein is involved. So these cases are condemned as inoperable cases. So in a nutshell, let me tell you again, T1A involvement of only lamina propria, simple cholecystectomy enough. T1B with the negative factors, with the positive factors. With the negative factors, simple cholecystectomy enough. With the positive factors, we should do a extended cholecystectomy of 2 cm margin. T2, we should do a radical cholecystectomy. T3, we may do a, what is T3? Involvement of one adjacent organ. We may need a radical cholecystectomy or a central hepatectomy or a extended right hepatectomy will be needed. Inoperable. So please don't forget this T-staging based management of gallbladder cancers. So these are the T-staging based management of gallbladder cancers. So N1, N2, what is TNM staging? N1 is for nodes. Nodes positive in cystic duct, CBD, or in the hepatic artery, or in the portal vein. So nodes, pericholectal nodes. These are all pericholectal nodes. So distant nodes, periaortic nodes, pericaval nodes, near the IVC, pericaval, superior mesenteric artery nodes, celiac nodes all come under N2. N1 is nodes very nearby, N2 is nodes very far away, M1 is METs. So this is what we say as the cholecystectomy protocols. So what are the methods of doing resection in case of gallbladder and bile duct cancers? Please don't forget, in gallbladder cancers, these are the surgeries I want you to remember for exam. Please don't forget them. So I hope you understood what is the management of gallbladder cancer based on T-staging. So otherwise the T-staging is not important in most of the cancers in GIT. So in this place, I would like to make you understand, based on T-staging only we manage. So I want you to know that T-staging. T1A is lamina propria, T1B is muscle layer, there is no submucosa, so it directly goes to muscle layer. T2 is serosa, T3 is one organ, T4 is more than one organ. So this is a T-staging management of gallbladder cancers. So now I'm going to tell some important recent advances in gallbladder cancer management. Recent advances in gallbladder cancer management, I would like to tell you, please remember them. So now, previously when we are doing relaparotomy for a specimen showing gallbladder cancer, when we are going for a relaparotomy, these are the port sites means in those days we used to resect the port sites also. In those days. Now latest recommendation is no need to resect port sites. Please remember, no need to resect port sites as per latest protocol. So this is one recent advance. So previously in those days when we are doing relaparotomy, we go and remove the ports. The port sites also will be removed while doing relaparotomy and doing a liver resection. But latest protocol is no need to do port site excision because if at all there is going to be recurrence, it can happen anywhere, not only in the port site places. So please don't forget, this is one point I want to tell you. And number 2, if you already diagnosed it is a gallbladder cancer and you are planning to do a radical surgery. So you are planning a radical surgery for a gallbladder cancer. For a GB cancer, if you are planning a radical surgery, one investigation is accepted now before going for radical surgery, that is diagnostic laparoscopy. So we must put diagnostic laparoscopy before going for laparotomy and resecting the tumor because in around 30 to 40% of the patients who are thought to be operable gallbladder cancers will have small peritoneal deposits or small liver mets, all those things, and they are condemned as inoperable on diagnostic laparoscopy. So in a cancer gallbladder, diagnostic laparoscopy is an accepted staging investigation. It is a staging investigation. Please remember, in a gallbladder cancer, DLAP is a staging investigation accepted. Okay. And scenario number 1, let me tell you some scenarios in gallbladder cancer. Scenario number 1, you are doing laparoscopic cholecystectomy for multiple gallstones, and that specimen is sent to the pathologist. The pathologist is finding out multiple stones. Along with that, there is a cancer found inside the gallbladder. Along with the stones, and pathologist is calling you, sir, please see, there is a cancer in this patient, in the specimen. What you should ask the pathologist immediately? The first question you will ask the pathologist is, madam, can you please tell me what is the staging? Because the further management depends on staging. If it is T1A, already done lap cholecystectomy is enough. If it is T1B, that is tumor involving muscle layer, you will ask the madam whether there is any node involvement, whether margin is positive, whether there is perivascular invasion or neural invasion present. If everything is negative, lap cholecystectomy is enough. If any of them is positive, we have to do extended cholecystectomy by reopening the abdomen. Call back the patient to hospital and reopen the abdomen and do extended cholecystectomy. If the pathologist is telling, sir, this is T2, that means the tumor is infiltrating up to serosa, no doubt you should go for radical cholecystectomy by relaparotomy. So, incidentally detected gallbladder cancer. Incidentally means in the specimen detected gallbladder cancer, what will you do? Incidentally detected gallbladder cancer, what will you do? The further management depends on staging. If it is T1A, lap cholecystectomy enough. T1B with the positive points, extended cholecystectomy done. T2, radical cholecystectomy done. Will you get incidentally T3 or T4? You will never get T3 or T4 incidentally. If you are getting T3 or T4, you are the worst surgeon. Remember it. Because T3 means the tumor is already involving one organ. The tumor is already involving more than one organ. The moment you put the laparoscopy itself, you can see there is a tumor. So definitely you don't get T3 and T4 in the specimen incidentally. So that is coming as scenario 2. You are a general surgeon. Please remember, you are a general surgeon beginner. You are a general surgeon beginner. You are putting a port inside. The moment you put a port inside, you are seeing there is a cancer in the gallbladder. There is a cancer in the gallbladder like this. So what will you do now? You are a beginner. The moment you put one primary port, you are seeing there is a cancer in the gallbladder. What you should do? You are not experienced or well versed in biliary surgeries. Remove the port and refer the patient to a hepatobiliary surgeon, hepatobiliary pancreatic surgeon. Refer the patient. Refer the patient to a hepatobiliary pancreatic surgeon if you are a general surgeon. Scenario number 3. You are a hepatobiliary surgeon. The moment you put a port, you are seeing there is a cancer in the gallbladder infiltrating nearby structure. What do you do? Or you are suspecting that is looking like a cancer. What will you do? Immediately convert to open technique and proceed. Please remember, immediately you convert from laparoscopy to open and proceed. You should not continue laparoscopy hereafter. And you convert to open and treat according to stage. So if you are a well-versed surgeon, you must continue the procedure by converting it to open technique. If you are a general surgeon, remove the port and refer to the hepatobiliary surgeon. All these questions have come in exam. All these questions have come in AIMS exam. So gallbladder cancer, please be thorough. And post-operatively, we can advise them chemotherapy. The commonly given chemotherapy regimen is based on gemcitabine chemotherapy is advised for them. Gemcitabine based chemotherapy is given for gallbladder and pancreatic cancers. So gemcitabine based chemotherapy is given for gallbladder and pancreatic cancers. And now coming to the bile duct cancers, though not so important for PG entrance, let me just give an outline. Bile duct cancers are more common where? In the hilum. They are more common in the hilum. The predisposing factors is the only question you can get in this. Predisposing factors. The predisposing factors in Bailey is given as heading as inflammatory causes. As inflammatory causes. What are the inflammatory causes? You know, they are primary sclerosing cholangitis, ulcerative colitis, and hepatitis C virus infection, and oriental cholangiohepatitis. So primary sclerosing cholangitis, ulcerative colitis, hepatitis C, oriental cholangiohepatitis are the inflammatory causes. And then parasitic causes. What are the parasites that can cause cholangiocarcinoma? Means Clonarchis sinensis and Opisthorsis viverni. Opisthorsis viverni are the parasites which can cause cancer. So inflammatory, parasitic causes, and chemicals. There are many chemicals which can cause cancers. They are thorium, they are asbestos, and there is vinyl chloride. These are the chemicals which can cause bile duct cancers, and congenitally there are some pathologies which can cause bile duct cancer. This is classification from Bailey and Lau. The congenital causes are Caroli's disease, and Caroli's disease, what is it? Type 5 choledochal cyst, that is Caroli's disease, and other types of choledochal cyst. So choledochal cyst type 5 is known as Caroli's disease, and other types of disease also causes cancer. And another important thing is bilioenteric bypass. Post-operative causes include bilioenteric anastomosis like hepaticojejunostomy, choledochoduodenostomy. So these are all bilioenteric anastomosis, hepaticojejunostomy, choledochoduodenostomy are all some anastomosis. Because of the anastomosis, there will be reflex of the irritants into the bile duct, and that can cause bile duct cancer. So please don't forget inflammatory causes, parasites. This question came in recent exam in JIPMER. Clonarchis sinensis, Opisthorsis viverni causes cholangiocarcinoma, chemicals, congenital, post-operative are the various causes of bile duct cancers. So bile duct cancer, the most common type is adenocancers. They are all adenocarcinomas. And adenocarcinomas, the most common type is sclerosing type. Sclerosing type is the most common type, and the sclerosing type is the one which causes worst prognosis. Please don't forget that is the one which causes worst prognosis. There are other types like papillary and nodular type. Papillary, nodular, sclerosing are the various types of adenocarcinoma. Papillary have the best prognosis, and sclerosing have the worst prognosis. Okay. So now, investigation of choice for bile duct cancers, already told you MRCP with MR angio should be done. Because only with this MRCP and MR angio we can find out the vascular involvement is present or not. And tumor marker is CEA and also CA19-9 is done. And for this cancers, there is a classification for this cancers known as bismuth correlate classification. So don't get confused, this bismuth correlate. So bismuth correlate is for cancer. Only bismuth is for bile duct stricture. This is bismuth correlate classification, in which the type 1, the cancer is seen away from the confluence. So if this is a bile duct, the cancer is seen away from the confluence. That is type 1. Type 2 is a cancer involving the confluence but not going to the secondary ducts. The cancer is involving the confluence but not extending to the secondary ducts. So 3A and 3B are cancer at the confluence extending to the right side. The confluence cancer extending to the right duct is 3A, and the cancer in the confluence extending to the left duct is 3B. So either to the right side or left side. 3A means extending to right side, 3B means extending to the left side secondary hepatic ducts. 4, well known answer, it is extending to both sides. Secondary ducts of both sides is involved. It is inoperable case. So please remember, it is inoperable. When it is extending to both sides, it is inoperable. So 1 is away from the confluence, okay, involving only the common hepatic duct level. 2 is coming up to the confluence. 3A is right side secondary duct involved. 3B is left side secondary duct involved. 4 is inoperable, involving both side secondary ducts. Both side secondary ducts are involved, is known as type 4. Okay, this is Bismuth correlate classification of cholangiocarcinomas. Please don't forget, this is a classification of cholangiocarcinomas. For 3A, what is operation we do? What is operation we do for a 3A? So this is segment 2, 3, 4A, 4B, 5, 6, 7, 8. So please understand, this is the staging which you will be knowing more better in liver chapter. In 3A, if the cancer is extending to the right side secondary ducts, we remove these segments. What is this operation known as? So segment 4A, 4B, 5, 6, 7, 8 is removed in a 3A. This is known as extended right hepatectomy, now known as right side trisectionectomy. Now the new name is right trisectionectomy. For a cancer extending to the left duct like this, we remove the ducts, segments 2, 3, 4, 5 and 8. So that is for 3B. We do a extended left hepatectomy in which segments 2, 3, 4A, 4B, 5 and 8 are removed, and this is now known as left trisectionectomy. So please remember, 3A is extended right hepatectomy, 3B we do extended left hepatectomy. These are the two surgeries done for operable cases. The problem with bile duct cancers is most of the time they come to hospital as inoperable cancers. So what do you mean by inoperable or unresectable cancers? Inoperable or unresectable cancer of hilum. What are the criteria to say they are inoperable? Already told you type 4, bismuth correlate is inoperable. Already told you one. Bilateral secondary radical involvement is inoperable, type 4. And another type, main portal vein is involved. Main portal vein involvement is inoperable. Main portal vein is involved by the tumor. 3, the right side hepatic duct involved. So right side hepatic duct involved. Otherwise, right lobe is atrophied. Right lobe is atrophied plus contralateral or left side portal vein involvement. You can also say on the opposite side. So one side duct is atrophied or lobe is duct is obstructed or lobe is atrophied, with the contralateral portal vein is said to be inoperable. Okay, so one side atrophied liver, opposite side portal vein involvement is inoperable. And fourth one, if there is liver mets, if there is peritoneal mets, if there is ascites, these are the other criteria for inoperability. These are all the places where a bile duct cancer is inoperable. Please don't forget these criteria for inoperability of bile duct cancers. Okay, the criteria of inoperability of bile duct cancers. Now let me show you the images of gallbladder cancers. So please don't forget the predisposing factors of both cancers. The major predisposing factor of gallbladder cancer is gallstone, and according to each stage we manage. Now see this image and tell me what is the staging. This is a cancer involving gallbladder. Serosa. You can see the tumor is coming up to the serosa. So what is the stage? Serosa is T2. So what should I do? For a T2 cases, I will do a segment 4B and 5 resection known as, what is operation? This operation is known as radical cholecystectomy operation is going on for this case. And you can see this is one of my patient, one of my friend, general surgeon. He has put a port. On putting the port, he found something abnormal in the gallbladder. So he didn't do surgery and referred the patient to me. And I found out it is a tumor going up to muscle layer. So I opened up and I did a 2 cm margin excision of liver like this. 2 cm margin of liver excision done like this. So this is a extended cholecystectomy done for the patient. So bismuth classification of bile duct cancers, please don't forget. So 1 is away from the confluence, 2 is at the confluence, 3A is involving the right duct, 3B is involving the left, and 4 is involving both side secondary radicals. Okay. So 3A we should do extended right hepatectomy, and 3B we should do extended left hepatectomy. Okay. And bile duct cancers, if there is a cancer in the mid of the CBD, we should give margin clearance and cut it. So what is the treatment for cancer at each place? So hilar cancers, just now I told you, mid CBD cancer, we can resect it, giving proximal and distal clearance. Distal CBD cancers will be operated by Whipple's. We will be discussing it in pancreas chapter. So we will be doing Whipple's operation for distal CBD cancers. So hilar cancers we are discussing like right hepatectomy or left hepatectomy, and mid CBD we resect only the bile duct and do hepatic vaginostomy. And for distal CBD cancers, we will do Whipple's operation. Please don't forget, we will do Whipple's operation. So the criteria of inoperability, please don't forget the criteria of inoperability, and that completes the tumors in this chapter. So malignancy in bile duct system is a high yield topic for AIIMS and institute exams, though less asked in PG, NEET PG, it is more commonly asked in AIIMS. So just have an idea about these topics. Okay, thank you.